Welcome to eNormous Nephrology. My name is Dr. Irfan Moinuddin. I am Assistant Professor of Internal Medicine at the University of Illinois at Chicago, and I am a general and transplant nephrologist at Stroger Hospital of Cook County and Providence Hospital of Cook County. This talk will be on autosomal dominant polycystic kidney disease. All of my talks can be found at youtube.com/@irfanmoindin-kidney. So the first question is, why do cysts form in the first place? We all know about the burgeoning data on tolvaptan and the problematic nature of increasing kidney volumes, increasing cystic replacement of kidney parenchyma, and we're using medications and blood pressure control and other things in order to reduce the progression of chronic kidney disease in ADPKD. But that is a backward approach. How can we prevent cyst formation in the first place? That's the major question, and we have not arrived at the answer to that yet, but we have arrived at a detailed understanding of what contributes to cyst formation in ADPKD and why do cysts arise, and that is what we'll talk about before we delve into the clinical presentation of ADPKD and the management of ADPKD. So first thing is that cysts originate as outpouchings of tubular epithelium. In ADPKD, these cysts are derived from every segment of the tubule, and they close off from the nephron quickly after initiation of dilation. In autosomal recessive polycystic kidney disease, these cysts derive as expansions of collecting tubules and remain in contact with the nephron of origin. This is an important point, is that the cysts increase in size and in number, and they replace the parenchyma of the kidney. But in ADPKD, you don't see that decrease in GFR initially as the cysts are growing and the number of cysts are increasing and the parenchyma is being replaced. In fact, you see sort of a stable kidney function up until almost 66% of the kidney is replaced by cysts. And then that's when you see a dramatic decline in GFR. So you don't see that initial decline in GFR as those cysts are growing and as the cysts are replacing the parenchyma of the kidney. So how do cysts form? I came up with this mnemonic, SPAM, SPPAAAM. These are the things that play a role in the processes that lead to cyst formation, in the mechanisms of cyst formation. And this mnemonic helps you remember the various components of these processes. So secretion is important because you have to secrete fluid into the cyst. As you know, cysts are fluid-filled structures. There has to be proliferation of the renal tubular epithelial cells. There has to be mispolarization. The normal kidney tubules are polarized with respect to growth factors, sodium potassium ATPases, and the cystic fibrosis transmembrane regulator. And we'll talk about how mispolarization can lead or contribute to cyst formation. So not only are the cysts replacing the kidney parenchyma, not only are the cysts growing in size and in the number of cysts, but the normal kidney parenchyma, the non-cystic tubules are undergoing apoptosis. Adhesion is important, whether it's cell-to-matrix adhesion or cell-to-cell interactions. Um, and cilia are important because cilia sense shear, and they're important because the tubule needs to grow in length and not in width, and that sensation of shear helps to maintain normal tubular structure. And then we'll talk about morphogenesis. Um, these are the various components of the mechanisms of cyst formation. So this is a tubule, and this is the normal structure of the tubule, and here is the normal structure of the tubule. And here you can see that a cyst is beginning to form. And this diagram will help explain some of the mechanisms. In particular, we're talking about proliferation. The growth factors should be basal, as you can see in the blue. So towards the lumen of the tubule is the apical surface, and towards the interstitium is the basolateral surface. So the growth factors should be basal. And in the cystic areas, the growth factors are actually apical. Um, and the fact that the growth factors are apical as opposed to basal is fundamental to renal tubular epithelial proliferation. So these growth factors are going to act autocrine and paracrine. So you have autocrine and paracrine proliferation of renal tubular epithelial cells. And then you have the sodium potassium ATPase. It should be alpha 1, beta 1. And in ADPKD, the sodium potassium ATPase is alpha 1, beta 2. And we'll talk about this is actually persistence of beta 2, which is present at the fetal stage. So ADPKD is actually kind of persistence of fetal proteins. And this is a theme that we'll arrive at again and again because there are many proteins, many fetal proteins that can persist and that can give rise to cystic structures in ADPKD. So the first thing is that the sodium potassium ATPase in a normal tubule will be basal. And by its basal presence, it will cause sodium and fluid reabsorption. If the sodium potassium ATPase is apical, then it will actually cause secretion of fluid into the cyst. So not only is the sodium potassium ATPase alpha 1 beta 2, but it's actually mispolarized. And that contributes to fluid secretion into the cyst. And then finally, there is increased matrix adhesion. So normal matrix adhesion allows for normal tubular structure, whereas increased matrix adhesion kind of pulls the cells into a cystic morphology. So those are the things that are important in cyst formation. The renal tubular epithelial proliferation is actually complete soon after birth. But in ADPKD, there is continual proliferation of cyst lining epithelia throughout childhood and adulthood. And that's in part because of these mechanisms that we talked about. Just as an aside, in vitro epidermal growth factor secreted by the thick ascending limb of the loop of Henle can stimulate proximal tubular epithelial proliferation. So that's just more evidence that these growth factors are important. And finally, there is aberrant overexpression of the HER2 new or ERB2 member of the growth factor. Again, this is a fetal protein. So cyclic AMP has both proliferative and anti-proliferative effects. And there are many factors that regulate this. And we'll talk about vasopressin, and that's the one that currently is playing a major role in terms of pharmacological interventions. And then, of course, receptors on cell membranes of the principal cells of the collecting tubule, the PTH, calcitonin, protein kinase A. These are all other factors that modulate the proliferative and antiproliferative effects of cyclic AMP. Vasopressin, we all know about. That's why tolvaptan is thought to reduce cystic proliferation and replacement of kidney parenchyma by cysts. So cyclic AMP in ADPKD and in ARPKD, in the presence of polycystin, exerts a stronger proliferative effect. So in ADPKD, we have an abnormal polycystin. Therefore, cyclic AMP has a proliferative effect. So not only do you have cysts replacing the parenchyma of the kidney, you actually have apoptosis of non-cystic tubules. Apoptosis, as you will recall, is characterized by cell volume reduction, surface blebbing, chromatin condensation, and DNA cleavage, leading to apoptotic bodies. So expansion of cysts is accompanied by loss of normal nephrons. A normal polycystin conveys resistance to apoptosis. Secretion, so fluid and electrolyte homeostasis requires coordination between polarized transporters and sodium ion gradients established by sodium potassium ATPase in the basal membrane of the renal tubular epithelium. In ADPKD, sodium potassium ATPase is mispolarized to the apical membrane, and there is a failure to downregulate transcription of the fetal beta 2 subunit isoform, favoring the assembly of the alpha 1 beta 2 sodium potassium ATPase heterodimers that are inserted into apical cell membranes of cystic epithelium. Expression of fetal proteins of afterbirth is a major pathological feature of ADPKD. And this is where intense research needs to be conducted, because we really need to figure out how to prevent these persistence of fetal proteins, and how we can prevent cystic formation in the first place, instead of kind of working backward, where the cystic the production of cysts, and these mechanisms are already in place, and now we're working backward to reduce cystic proliferation, reduce increase in volume of the kidney, and preventing a progression of chronic kidney disease. Can we prevent it in the first place instead of working backwards? So polycystic kidney disease may be a failure of normal maturation. Fluid secretion. In normal adults, the cystic fibrosis transmembrane regulator is expressed on apical plasma membranes. In ADPKD, it's highly expressed and functional on apical membranes. And this may be due to loss of normal polycystin function. Cystic fibrosis transmembrane regulator function is cyclic AMP dependent, and cyclic AMP can promote transepithelial fluid secretion. Aquaporin 1 and aquaporin 2 are also highly expressed in ADPKD cysts. Again, mispolarization seems to be a major mechanism of cyst formation in ADPKD. Again, there's a failure to downregulate fetal patterns of gene expression. ERB2 is seen in normal fetal kidneys and in ADPKD cystic epithelia. It is not expressed in normal adult kidneys. Failure to switch off the fetal beta 2 subunit of sodium potassium ATPase with apical alpha 1 beta 2 sodium potassium ATPase distribution in ADPKD cystic kidneys is also important. In normal kidneys, you have the alpha 1 beta 1 heterodimers, and these are located to the basal membranes. So normal renal tubular epithelium is characterized by specific apico-basolateral polarization of numerous membrane proteins. And loss of polarity of these proteins in cystic kidneys can lead to abnormalities in direction of ion and fluid transport, lumen dilation, and aberrant increases in proliferation. And polarity may in part be controlled by polycystins. So cell matrix and cell-to-cell interactions are important. And there is in ADPKD, there is a defect in normal focal adhesion turnover. So there's persistent adhesion, there's increased adhesion, and there's poor migratory function. And a majority of cystic kidney proteins are expressed in focal adhesions. So all these proteins that are implicated in cystic disease are actually present in focal adhesions. They're also present in cell-to-cell junctions, and they're present in cilia. E-cadherin, which is a component of the cell-to-cell adherens junction, is replaced by the more fetal isoform N-cadherin. So again, another fetal protein which persists into childhood and adulthood. Polycystins are localized to apical cilia, basal focal adhesions, and lateral cell-to-cell junctions. Mutations in cilia proteins lead to cystic kidney disease. No structural alterations have been identified. Functional alterations are implicated. Apical cilia are very important in sensing shear. Adhesions will sense tensile strength of cell-to-matrix attachments, and cell-to-cell junctional complexes sense forces between cells. And this is very important because the tubule needs to grow in length, and sensing shear, sensing cell-to-matrix attachment, and sensing cell-to-cell junctional complex strength is important because you want those tubules to grow in length and not in width. When cilia are abnormal, regulation of luminal diameter is compromised, leading to formation of cysts. So let's talk about morphogenesis. Here you can see that the tubule is kind of growing in length and has a normal shape. You kind of go through these U-shaped structure to a S-shaped structure, and then the tubule grows in length. That is because you have normal polycystin in the adhesions, in the cilia, and in the cell-to-cell junctions. If you have abnormal polycystins, which is shown in red here, then you have development of cysts because the tubules are growing in width and not so much in length. And this is when you have one gene which is abnormal. If both genes are abnormal or absent, then it's actually lethal because the tubules do not develop. Now let's jump into clinical presentation. Now that we understand what we know about how cysts form, now once you have cystic disease, once you have ADPKD, how does it present and how should you evaluate it and how do you manage it? So typically, the presentation includes hypertension, proteinuria, hematuria, abnormal GFR, and then other presentations can include kidney hemorrhage, nephrolithiasis, and urinary tract infections. So sometimes a patient will come to you for routine evaluation in an asymptomatic patient with a positive family history of ADPKD. My family has ADPKD. Um, how should I be evaluated? What should I be looking out for? How can I prevent progression of CKD? So that's how a patient may present. Or you may be working up new onset hypertension and you may find ADPKD. Or you may be doing an imaging study for other reasons like pregnancy, trauma, spinal pain, and then ADPKD may be an incidental finding. Or you may the patient may present with hematuria, pyelonephritis, kidney stones, and you may end up finding ADPKD because of these symptoms, which are closely related to ADPKD. If the ultrasound shows large kidneys with extensive cysts, the diagnosis is relatively clear-cut. And everybody should get genetic testing. Genetic testing is very important. The mutation can determine prognosis and also can determine whether certain treatments are appropriate, such as tolvaptan, etc. And once ADPKD is established, a baseline MRI to calculate height-adjusted total kidney volume is appropriate and important to assess for whether the patient is high risk or low risk, and to determine risk for progression and need for disease-modifying treatments, including tolvaptan. If the ultrasound is not dramatic, not obvious, then certain ultrasound criteria have been developed based on collective practically acquired data. So if they have a family history of ADPKD and they're 15 to 29 years of age, then a total of 3 or more cysts would make you consider ADPKD. And the presence of ADPKD is actually quite likely, 70 to 95%. And if they're 30 to 39 years, also 3 or more cysts. Here the sensitivity is pretty much 95 to 97%. And if they're 40 to 59 years, the criteria is 2 or more cysts in each kidney. If there is no family history of ADPKD, then there are no established criteria. But if there are more than 10 cysts in each kidney, then ADPKD should be considered. Each cyst should be more than 5 millimeters. Of course, if the kidneys are markedly enlarged, that would be consistent if there's significant cystic disease, which would be more than 10 cysts per kidney. If there are liver cysts present, you should explore the kidneys and see if renal cysts are present. Again, genetic testing, genetic testing, genetic testing. All patients suspected to have ADPKD should have genetic testing. And we'll talk about that in subsequent slides, how genetic testing and the genetic mutation contributes to knowledge of prognosis and progression and propriety of interventions. So if they don't have a family history of ADPKD, is it a new mutation or something like that? No, most of the time it is inherited. And the affected parent may have died without a diagnosis or may have a mild form of the disease that has gone undetected. In 5% of the cases, the disease may be due to a new mutation or due to mosaicism. Differential of ADPKD, not ADPKD phenocopies, but actual cystic disease would be multiple benign cysts, assuming it's not markedly consistent with ADPKD. Obviously, if they have tons and tons and tons of cysts, then it won't be multiple benign cysts. Localized kidney cystic disease has been reported. This is a rare, non-hereditary, non-progressive, benign condition where multiple cysts form in one kidney, but not the other or any other organ. Acquired kidney cystic disease is in advanced CKD or in dialysis patients. Medullary sponge kidney, also thought to be due to abnormal development of kidneys during fetal growth. This is a rare congenital disorder characterized by the presence of small fluid-filled cysts in the medulla. And then parapelvic cysts can sometimes be confused for renal cysts. Let's jump into management. First thing is that you're going to see a patient with renal cysts. You're going to confirm the diagnosis of ADPKD. And after that, once the diagnosis of ADPKD is confirmed, of course, you're going to do genetic testing, but you're going to do an MRI because you need to have that height-adjusted total kidney volume. And we're going to see an example of that in the upcoming slides. And you're going to classify it according to the Mayo classification. If it's 1A or 1B, it's low risk, and you can repeat the image in 3 years. If it's Mayo class 1C, 1D, or 1E, it is a rapidly progressive ADPKD. If your GFR is greater than 25, greater than or equal to 25, and your age is 18 to 55 years, then you should consider tolvaptan. In patients who are younger than 18 or older than 55, the risk-benefit ratio of tolvaptan is uncertain. And in fact, the ADPKD disease may actually be quite stable, especially if they're like in their 70s or 80s, and monitoring may be more appropriate. So other than tolvaptan, blood pressure control is very important. Blood pressure that is uncontrolled will almost inevitably lead to progression of CKD in ADPKD. And ACE inhibitors or ARBs are the medications, the antihypertensive medications of choice in ADPKD. Sodium restriction, salt is never a good thing. Salt is a poison. So that's also the case in ADPKD. Sodium restriction is very important. Hydration is very important. You want to shoot for a urine osmolality of less than 280. Maintain a normal BMI, moderate caloric restriction, normal cholesterol, LDL less than 100, HDL greater than 50, low threshold for statins, moderate protein and phosphorus restriction. You want to have a normal phosphorus, and you want to have a normal sodium bicarbonate, serum bicarbonate of greater than or equal to 22. This is the Mayo classification. As you can see, this is the height adjusted total kidney volume. This is the age, and you can graph age versus HTTKV to arrive at the Mayo classification. Class 1A and 1B are low risk. Class 1C, 1D, and 1E are high risk. This is to tolvaptan or not to tolvaptan. So HTTKV is in part how you decide whether tolvaptan is appropriate. And other factors, of course, are appropriate, including age and GFR. Intracranial aneurysms and brain hemorrhage is important. In the general population, the prevalence of an aneurysm, intracranial aneurysm, is 2.9%. And if they have a family history of an intracranial aneurysm or subarachnoid hemorrhage, it's a little bit higher, 3.4%. In the ADPKD percent is much higher, 12.9%. And if they have a family history of intracranial aneurysm or subarachnoid hemorrhage, it rises to a whopping 17.1%. Ruling out intracranial aneurysm in a patient with family history of intracranial aneurysm or subarachnoid hemorrhage is very, very important. If the screening is negative in people with a high risk of intracranial aneurysms, then you can rescreen in 5 to 10 years. When an intracranial aneurysm is identified, then a multidisciplinary team approach is indicated, and surgical intervention should be considered. Valvular abnormalities are present in 25 to 30%. Mitral valve prolapse is the most common, and aortic regurg is commonly present, as well as mitral and or tricuspid regurg. Some patients will present with chronic flank or abdominal pain, sometimes really severe. What can you do about chronic flank or abdominal pain? Physical therapy. You should begin with physical therapy, weight loss, non-pharmacological approaches like TENS, lidocaine patch, support garments. And then if you have to, then you may have to use pain medications or neuropathic medications or clonidine. And then in severe cases, or if the cysts are large, particularly if they're more than 500 cc's in an individual cyst, then cyst aspiration and sclerotherapy may be appropriate. And then a pain team involvement may be appropriate. So referral to a pain physician may be appropriate for consideration of spinal cord stimulator, nerve blocks, or renal denervation. 25% of patients will have kidney stones. Over half may be uric acid based. And then, of course, the imaging modality of choice is a CT without contrast. And if there's obstruction, then you need to get the urologist involved. What contributes to progression of CKD in ADPKD? There are some factors which are definitely associated, some which are proposed, and some which are associated with um, lesser severity than the more pronounced factors, such as decreasing GFR, increasing total kidney volume, hypertension, UTIs, hematuria, proteinuria, um, and increased BMI, increased caloric intake, increased salt intake. These are definite risk factors and indicators of a poor prognosis. And then so factors that are associated with less severe disease um, are things like gender and certain genes. And then some the effects are proposed but not proven, such as diabetes and nephrolithiasis, smoking, caffeine, etc. Of course, PKD1 is by far the majority of patients that have ADPKD. So the most of patients who have ADPKD will have PKD1. Here you can see that it's almost like 60 to 70% have PKD1. There is a distinction between truncated PKD1 and non-truncated PKD1. Truncated implies something like a abrupt stop codon because of the mutation. So you have a resultant very small protein in the place of a normal polycystin. And the truncated PKD1, it has the poorest prognosis. And that, unfortunately, is the most common mutation that leads to ADPKD. And then after PKD1, you have PKD2, and then 5% have other mutations that have been identified. The third most common being IFT 140, followed by ALG8 and other genes. And then there are about 16% who do not have an identified mutation. And then there are those ADPKD phenocopies, and we'll briefly mention those, including HNF1B, UMOD, and Alports. So it's probably a good idea to name the mutation when you're referring to a patient with ADPKD. So if they have PKD1, then you can say that this patient has ADPKD hyphen PKD1, or this patient has ADPKD hyphen PKD2, or whatever mutation they have. And then if it's unknown, of course, it's unknown. This is just a visual collage of ADPKD genes. This is the truncated PKD1, a non-truncated PKD1, PKD2, IFT140, which is the third most common mutation that has been identified so far, followed by other mutations that have so far been reported. And there will be many more genes that will be reported in upcoming years. But what will not change is that this will predominantly, these mutations will involve adhesions, cell-to-cell junctions, or cilia, because that's where the polycystins are present, and the other proteins that give rise to cystic diseases are likely also present in those regions. Just a brief comment on prognosis. PKD1 has the worst prognosis. And here you can see that 50% renal survival occurs at an age of 57.5 years, as opposed to 70 years for PKD2. IFT140 is the third most common cause of ADPKD. And biallelic is very bad. It's diagnosed in early childhood, and kidney failure occurs in childhood. But if it is diagnosed in adulthood, it's most likely monoallelic. Monoallelic means that you have two alleles, but for some reason, one allele is not expressed. So basically, only one allele is expressed, and that allele is producing an abnormal protein, which leads to the uh, cystic disease. And in this particular case, the ADPKD is milder, and the median age of diagnosis is about 52 years. And you can see here that it is relatively milder. Um, this is PKD1 with the worst GFR trajectory, PKD2, and then IFT 140. And here you can see the gender difference. So again, females do have a little bit better prognosis with slightly slower GFR decline. DNA JB11 does have GFR decline, which is kind of linear. So there's decrease in GFR, which is kind of consistent. But again, you don't see ESRD until kind of an abrupt junction, which is like around 65 years. But that GFR is declining. In fact, that GFR decline seems to start even as early as the 20s. Here's a gene which has a relatively good prognosis, GANAB. And here you can see that the GFR actually is quite stable, quite horizontal almost, as you get older and older. So genetics does play an important role, and better calculators will be available to determine risk, so that you can determine if, for example, tolvaptan is appropriate, or if what the risk-benefit ratio is. For example, I have some patients who had ADPKD diagnosed in their 70s, 80s, and obviously in those patients, the prognosis is relatively good. And because they're already 70 and 80, and you wouldn't use tolvaptan in those patients. And what kind of mutations do they have? That would be an interesting question, and genetic testing should be done, especially because you can inform the family members and relieve some anxiety in some cases. This is the PropKD calculator, which takes into account whether you have PKD1 truncating or non-truncating, or PKD2, or other factors such as gender, hypertension before 35 years of age, or first urological event before 35 years of age. So kidney volume is not the only factor. There are other factors to consider, including genetics, and more calculators will be upcoming. This is an example of ADPKD phenocopies, including Alport's syndrome, and then HNF1B and OFD1 are ADPKD phenocopies that you may run into. We will not delve into these in that much detail. So that's the end of my talk on ADPKD. Please visit youtube.com/@irfanmoindin-kidney. There you will see my board review talks, and you'll see other talks which I have conducted based on recommendations, requests from the audience, and based on my own inclinations. And recently, I've been doing a lot of hypertension talks, because education on hypertension, I think, is a very important area. and I would definitely want to put a dent in that area. So thank you very much. See you next time.